Hey guys, am I audible and visible? Just give me a second. Second. Hey guys, can you see me? Can you hear me? Second. I don't know what's happening. Hello guys, am I audible, visible? Sorry. Can you see me and hear me? If so, say me a hi, hello. Hello Lion, good evening Swati. Hello Priya. Hi Kamran. The merchandise, that's a concern. Fine. So welcome back once again to the RRR series. As you can see in today's name, we are going to discuss about disorders of healing. So yesterday in the class, we went through all the healing by primary intention. We had a look at the labile cell, the stable cell, and the terminally differentiated cell. And when a healing by primary intention happens, when a healing by secondary intention happens, and all those steps of healing, right? So this today's topic is a very small topic. So can we have a quick quiz on what are the things? I'll just ask you some random questions. I just want you guys to comment on the answer. Questions from both the first chapter, cellular adaptation, and also inflammation. If you guys are okay, put yes. Well, then we'll start some few random questions. I'm good, Priya. Hope you're good as well. So today's is very simple one. I'll finish it in maybe less than 10-15 minutes. Are you ready? Great. So what do you think will be the most common example of metaplasia? That's the first question. Maybe I'll take a new one and I'll keep adding the questions. I'll write the answer also lately at last, right? The most common example of metaplasia. Respiratory epithelium, Barrett's esophagus, squamous. Okay, got. I'll go with all the answers. I'll write all the questions, then we'll go with all the answers, right? Give me any one example of atrophy when it is irreversible, right? I just want an example of an irreversible atrophy. If you know any example, do let me know. What's an example of an irreversible atrophy? Okay, that's the second question. Just comment. See if it need not be right or wrong. I'm just going to add random questions. That's all. Okay. What is the most common cause of cell damage or cell injury or necrosis, for that matter, or most common etiology? Fine. Most common etiology: cell damage, cell injury, or necrosis. Again, whatever comes to your mind, comment on it. Okay, notochord, muscle wasting due to nerve injury, menopause. Okay, great. And next, give me in case of an dystrophic calcification, right? In case of a dystrophic calcification, what will happen to your serum calcium levels? Will it be normal, reduced, or elevated? Let's see if you guys can answer this. That's a fourth one. We'll take 10 questions, then we'll go to today's lecture. Okay, great. Decrease, normal, same. Fine. I want others also to answer. It's fine if you're wrong, ignore it. Just to let's discuss and definitely we'll learn more together. Right? I'll write few substances. I want you to tell a special stain. What's a special stain for glycogen? The special stain for glycogen, that's the first one. Special stain for let's take fat or an adipose tissue. That's a second one. Special stain for iron. That's a third one. Okay, we have got PAS with diastase. Great. Special stain for copper. That's a fourth one. Okay, oil reduced to dark black. We're getting almost every answers we require, right? Great. Special stain for melanin. Okay, we have Prussian blue there. What's the other name for Prussian blue? I am sure you know that. Pearl's Prussian blue, right? Amazing. Special stain for calcium. There are a few special stains which I want you to know. Today's PW Instagram channel had the feed of most of the common special stains along with the image. Just have a look at it if you're not have gone through it. Fine. Okay. Then, what is the hallmark of chronic inflammation, right? I told this multiple times. Please don't forget this. I want you to tell me the hallmark of chronic inflammation. We've got quite a few good answers. Whatever comes to mind when you think of it, chronic inflammation. Great, TDHF, that goes our answer, right? When you have an autoimmune disorder, I'm writing AI for autoimmune. I'm having a patient with an autoimmune disease. What do you think will be the cell or inflammatory cell which will be seen in microscopy? In any autoimmune disorder, what will be the inflammatory cell? Whatever comes to mind, again, put on the right answer. That's a seventh. I'll write all the answers once we're done with it, right? BCL2, pro or anti? MCL1, pro or anti? What? Pro or anti? Apoptotic gene. And BCLXS, pro or anti? Great, amazing, good answers of lymphocytes, uniform as well. Just comment which is pro, which is anti. BCL2, MCL1 and BCLXS, right? Fine. Tell me any caspase number, if you can remember, associated with pyroptosis. Okay. Anti-pro, anti-pro. Let's see if it's all three pro. Any caspases which is related to pyroptosis, the numbers, if you can recollect them. One more. And what is the function of an activated macrophage? If it's not, if you don't know, you can just even type I don't know. That's completely fine. But I just want you to participate. If it's something which is good for you, if you can retain it, remember it, recollect it, it'll be great, right? Activated macrophage function. Secretion. Great. So quite a few of you answered. Who were silent, very good, but still try to answer it whenever question is being put to you. Your very early part of your medical career, if you make mistakes, is completely fine, right? Let's go to answer. Most common example of metaplasia, most of you were right. It's a respiratory epithelial metaplasia. Secondary to smoking. Barrett's is most known metaplasia. That's definitely not common metaplasia. Simple logic. Smoking is way common than GERD. Irreversible atrophy. Quite a few embryological atrophies are irreversible, like notochord is the right answer, thymus is the right answer, menopause is also a right answer, right? I'd prefer menopause because it's more physiological atrophy than an embryological remnant, right? Most common cause of cell injury or necrosis, you're right, ischemia or hypoxia. Whatever it is, both are right. Ischemia or hypoxia is the common cause of cell injury. Dystrophic calcification. This is one thing quite a few of you kind of went into the wrong way. It will have normal serum calcium level. Calcium will never be reduced. In metastatic change in homeostasis, more calcium. Here it is going to be normal calcium. Stain for glycogen. Yes, it is PAS. PAS positive, diastase sensitive. Fat, Sudan black B, SBB, or an oil redo. Right, that's the right answer. Pearls, Prussian blue for an iron. Copper, we have orcine. Some of you must have forgotten this, right? And we also read about something called rhodamine or rhodonine, right? Melanin, though not important, we have your Mason Fontana. Mason Fontana is stain for melanin. And calcium, we have Voncosa. Voncosa is the commonest one. And also we have alizarin red, which is a very specific one. But Voncosa is definitely the commonest stain useful for calcium thing. Abhishek, generally, why it was done first 48 hours later? I'll ask the question that first. Because generally, any test done within 24 hours is a good one. Can you tell me what test did they do? If it's an antibody ELISA thing, it should not be very bad. That alone, I cannot say will affect the disease. ELISA is a very sensitive test. It can definitely pick them up, right? If it's a P24 antigen, I would prefer to have a 24-hour one or a Western blot 24-hour. ELISA is a bit of a stable test. It can well help. Wait for sure, right? Hallmark of chronic inflammation, you guys were right. Tissue destruction, healing by fibrosis. Still of acute inflammation, most of you were right. This is the one which most of you commented. I wanted you guys to comment for everything like this. Again, next time when a question is put forward to you, don't worry, please answer. BCL2 is anti-apoptotic. MCL1 is anti-apoptotic. This is pro-apoptotic. We had read a tiny clue saying that if L is there, it's a longer life, it's an anti-apoptotic. But BCLXS, that's the S, shorter life, pro-apoptotic, right? Caspase with pyroptosis, most of it didn't answer. We have caspase 1, 4 and 5. 1, 4 and 5, and the older book said 1 and 11 are related with apoptosis, pyroptosis, right? Activated macrophage, you guys were right. That's the last question. It was the function is secretion. Okay, Lalit, tell me the translation for that. Namaskar is the only one I can understand. Please help me with that. I think that's my today's homework. I have not forgot Sasfurna, by the way. Fine. Okay, now let's go ahead and go with today's class. So our today's lecture is supposed to be about the delay in wound healing metabolism, right? Okay, that was the thing for us. We have to learn about what are the things are going to delay wound healing and which might result in an abnormal wound healing as well, right? Before going to this, I just want you guys to answer, though there are few things there on the screen. Maybe I'll go to a different plain page where we are not going to learn anything. Fine, I'll put this page. Tell me whatever comes to your mind which can delay a healing of wound. You have gotten your injury. Tell me whatever comes to your mind which will delay wound healing. Abhishek, it's not about when it will die. It's about the stability of this person. There are multiple parameters, Abhishek. It cannot just like that answer that, right? Perfect. Diabetes, yes. Infection, yes. Kamran, one language at a time. Too much of language problems here, fine. Okay, location, yes. Okay. Fine, Lilith. I'll put that up at the end of the lecture, fine. Thrombocytopenia. Okay, that's a good one, Marshall. Anything else apart from infection, diabetes, which you think can delay wound healing? Can nutrition delay wound healing? Because for wound healing, I need WBCs, I need proteins, growth factors. If a person is not having protein energy malnutrition, can that delay wound healing? Yes, that can delay wound healing, right? For my wound to form, I need collagen. What vitamin is needed for collagen formation? Perfect. Vitamin C is required. Great. Zinc, cobalt might be required because those were involved in matrix metalloproteinases, right? So protein energy malnutrition, I'll have a problem. Vitamin C deficiency, I'll have a problem. Zinc, cobalt, I'll have a problem, right? Can any drug delay wound healing? This is what we saw in the last class when we ended it as well, right? Do you think any drug can delay wound healing? Any drug which comes to your mind? One of the commonly used immunosuppressant. Because if I suppress immunity, WBCs will not come, growth factors will not come, so obviously wound healing will be delayed, right? Steroids, great. Steroids can definitely delay wound healing. That's the concept of giving steroid for the COVID as well, right? I should not need a scar formation, fine, perfect, great. So drugs can delay wound healing. Your protein energy malnutrition, infection, absolutely right. Can, instead of saying diabetes, can I say any disease which will reduce blood supply to the wound? Can they delay wound healing? Yes. Diabetes causes vasculopathy, vascular problem. That will reduce blood supply. So obviously wound will not heal at the right way because blood supply gives nutrition, right? And like Ashwat said, movement can also delay wound healing, right? Perfect. So these are few factors which delays wound healing. Infection at the site definitely delays wound healing. That's why when you have any patient in future, when you see any patient coming to your OPD or casualty with a wound, what is the first step to be done? The first step to be done is clean the wound with normal saline. Don't clean with water. It should be with normal saline. You will see normal saline when you go to your hospitals in casualties. Clean it completely. It should be completely flowing, very forceful thing. So any dirt, anything which is there stuck there should be removed. Foreign body should be removed. I have to clean them first. It should be cleaned with normal saline. Diabetes, as we said, it causes vasculopathy. It will cause problems in the vessels, so there will be less blood supply, so I'll have a problem. Abhishek, see, there are multiple factors here. It will not affect if it's 48 hours and it's properly stored sample. It won't affect. If it's not properly stored, it will affect for sure. Like I said, I will not be the right person to judge it because I don't know what happened in the lab. Fine. Vitamin C is required for my collagen formation. So scurvy will have a delayed wound healing. Protein energy malnutrition will have a delayed wound healing for sure because this will reduce all the growth factors. I need growth factors for a proper wound healing. So growth factors are proteins. I will not be able to produce the protein, it will delay. Trace element also will cause a problem because this is involved in my matrix metalloproteinases. So the remodeling everything will be a problem. Gusa is angry. I'm not angry at all. If that's what you're asking, Lalit. Okay. Site of infection. At the site of infection, any movement, any tiny movement will delay wound healing. Any foreign body will delay wound healing for sure. That's why the first step in any wound is, especially like a bone fracture, immobilize. You have to make sure it doesn't move. If it moves, obviously this micro movement will cause tiny little bit of more trauma and it will definitely cause wound healing, right? Anything of reduced vascularity will reduce wound healing, like diabetes mellitus, right? These are few broader factors which can delay wound healing. But wound healing will definitely happen in all these factors. Maybe if my wound heals in 7 days, it might heal at 14 days or something of that sort, right? So these are factors which delay wound healing. Now let's have a look at something called an abnormal wound healing. I'm going to divide abnormal wound healing into two groups. One, abnormality in the granulation tissue formation. One, abnormality in the scar formation. Okay, abnormality in granulation tissue and abnormality in scar. The first thing is called an excess granulation tissue. Let's say, am I right in saying that when two people get the same injury, the scar of two people can be totally different, or will it be exactly the same? Will it be different or same? It will definitely be different. Some might have more scar formation, some might have less scar formation, right? So there are lots of things which plays a role in genetics. Your wound might delay a little bit, 1 or 2 late compared to the other person, right? Everything will be different. So genetics plays a major role, and we're not gone into that because I don't want to read that much in detail, right? But if there is a possibility, let's say I'm having a wound like this. There's a tiny wound here, there's a gap. The gap is the wound. And normally the granulation tissue forms like this, right? The red one is I'm writing GT for the granulation tissue, right? And now let's say if it's formed like this, the overlying skin can easily be laid down. So automatically my wound heals normally. This is what happens normally. I'm saying there's an excess granulation tissue. Let's assume the same example. I'm having a tiny wound here, but unfortunately the granulation tissue is coming here. It's becoming more excess. Anything excess or anything in your life, if it's excess, it's definitely abnormal for me. It should be always in a balanced state, right? Now here the granulation tissue is becoming more bigger. I'll just zoom this up. Do you think now the skin can close? Is there a possibility skin can close? Because I'm having granulation tissue on top, right? It cannot go like this and go like this and close, right? So can I say this will result in abnormal wound healing? It will for sure, right? So this is called an excess granulation tissue, or a very just a colloquial name, a proud flesh. It's actually a good thing, but it's too much of anything is bad for us, right? So that's going to be the problem here. So it's mechanically obstructing the skin to merge with each other. So what we do is, it's simple. The treatment is very simple. So I just excise them. Once I remove them, it's just here. I remove them. Obviously, wound will heal. The treatment is simple. You'll have to remove the excess granulation tissue. Once you remove, it will automatically take care of. Marshall, keloid is a bit different from excess granulation tissue. Like I said, keloid is a problem in the scar tissue. This is a problem in the granulation tissue, right? So it's a raw wound with too much of red color tissue. I remove them and you heal them. This you can easily see in patient diabetic foot ulcer. Did you guys go to the hospital and have a look at diabetic foot ulcer? Did anyone have a look? Anyone? So if you've seen a diabetic foot ulcer, this is pretty common there. That's why in your surgery department, they do something called a debridement. They debride the tissue, they remove the tissue in the corner, throw them away, so the healing happens a little bit proper. Next time when you go to surgery ward or OPD or a casualty, right? Which one, Lilith? uh, when you go to casualty, they just look at how they clean the wound. If there's something excess in the outside, they'll definitely remove that. That's what debridement means. That's what your proud granulation tissue means. Now let's go to scar formation. Like someone said, like Marshall said, keloid. So I have two things in scar formation: hypertrophied scar and keloid. I need to differentiate both. I'm sure some of you might have keloid formation. There are a few pointers for me here. Keloid is something which is common in Asian and African. Indian also is very common. There is no racial differences in case of hypertrophied scar. Hypertrophied scar, big scar, that's all. Keloid is also a big scar, right? So generally, hypertrophied scar is almost always asymptomatic. Keloid can be asymptomatic, or I can have pain or itching in the scar. The biggest problem of these two is they are cosmetic defects. They don't cause any symptom. I'll show you an image. This is keloid. What do you think is a trauma here? What is the injury here? Very simple one, right? What do you think is the injury here? What's the injury here? Perfect. The injury is nothing but a ear piercing. The person has pierced the ear. That's a tiny trauma, right? That trauma has resulted in such a huge scar. Right? So that is abnormal for sure, right? A tiny pinch or tiny prick here has resulted in a huge scar formation. This will not cause any symptom. Sometimes they can cause pain, but most of the time they are cosmetic appeal, that's all. Lalit, chalazion is a problem in the eyelid, right? It's some of the meibomian glands problem in the eyelid. So they scoop out the chalazion. That's a surgery for chalazion, right? Now, I need to differentiate hypertrophic scar from keloid because hypertrophic scar is a self-limiting condition. So if it's a self-limiting condition, do I need to treat them or not? No, Lalit. Chalazion is not a keloid. I need not treat an hypertrophic scar, but keloid is not self-limiting. It's permanent. I need to treat them. So definitely I need to differentiate whether it's a keloid or a hypertrophic scar because I need to manage the patient, right? So how do I differentiate this? Simple again. If I have an injury, again this black part is an injury, and hypertrophic scar will never cross the wound margin. I have a margin of the wound, this is the margin. It cannot go beyond the wound margin. It can go above, but not sideways, right? So this is the wound margin. It can never cross the wound margin. Now, here you guys only said that ear piercing is the problem. Can I say it has crossed the wound margin? Wound is only tiny. This might be the wound, tiny prick. Definitely it's way bigger than the wound margin, right? So that is a keloid. If any scar, if it crosses the wound margin, I call it a keloid. Again, for understanding, these two are the wound margin. It has definitely crossed the wound margin. I'm going to call it a keloid. They are differentiated only on clinical examination. Nothing else is required for me. I have a keloid. I don't know if you can see this. I hope it's visible. Let's see. Yeah, you can see a tiny scar here, right? I got this injury somewhere when I was in first year of college. So that is a keloid. It is not healed at all. It's healed, but the scar has not disappeared at all and it will be abnormal. I have a tendency of keloid formation, right? Yes, Lalit, it's growing bigger. It's an abnormal scar that looks like an outgrowth. You're right, it looks like an outgrowth there, fine. If the keloid is causing some problem, cosmetic appeal, yes, then I can treat them. Hypertrophy scar, like I said, wait and watch. Within 3 months, they will come back to normal. Because in 3 months, wound remodeling will happen, right? When the wound remodels, automatically, slowly, it will come back to normal. I need not worry about that at all. But keloid, on the other hand, requires treatment. The scar is nothing but collagen, right? And for the formation of collagen, I require TGF beta. Lalit, are you going to your ophthal posting? Why chalazion suddenly? Hello, future doctor. So TGF beta comes from macrophages. So what happens is when we give steroids, I have to give steroid injection into the scar. This will reduce macrophages, which will reduce TGF beta, which will alter the collagen formation, right? That's how steroids work. Or if it's very huge, if it's very, very huge, I need to resect them like this First thing is cut them a little bit if it's very huge, or just give an intralesional injection. This is enough. If I give an injection of steroid here, this will disappear. I'm not going to do, because it's not causing much of a problem. If it is a cosmetic appeal, yes, I need to give a treatment. Otherwise, treatment is not required. If there's a thing, definitely it requires treatment. If the person wants, you have to require the treatment. Fine. Okay. So that's about the difference between keloid and a hypertrophy scar. And these are the problems related to wound healing, right? So these are the problems with wound healing. So just a few quick things. We started with few one-liners from the first chapter. We'll keep doing this. Maybe one class I'll just discuss few MCQs for you. How many of you guys want me to discuss MCQs? Do you think is required for you guys? If you feel that MCQs are required, I'll go with an MCQ maybe in the coming class. Thank you, Lilith. Okay, I'll do one thing. I'll maybe in the next class, maybe 2-3 classes, we had DPPs, right? If you're in the PW Essentials batch, we'll have DPPs. I'll take the difficult questions in the DPPs. I'll try to discuss about the questions or some random questions from the first 2 chapters. We'll finish first 2 chapters slowly, then we'll go to the next one. Fine. Any doubts? Do let me know. If not, let's call it a day. Yes, Lilith, I am a pathologist. I work in genetic diagnosis. I am a pathologist. Fine. Okay, if there are no other queries, as usual, thank you. Bye-bye.